دكتور شريف على الدعوة. Our topic today, new measure to avoid post-liver transplantation renal impairment. Start with introduction. Acute kidney injury is common and significant complication after liver transplantation. It affects mortality, hospital stay, and exhaustion of resource. Reported incidence of acute kidney injury ranging from 5 to 90%. This wide range of variation due to non-uniform definition. At 1 year post-transplantation, about 90% of patients develop CKD. This percentage will increase with time at 5 years and 15 years. Causes of acute kidney injury, it is divided into pre-transplant, peri-transplant, and post-transplant. Pre-transplant, original disease due to liver disease, diabetes, and hypertension, or hepatorenal. Pre-transplant mainly due to volume loss, hypotension, and acute blood loss, and medication also. Post-transplant, CNI exposure, diabetes, and hypertension. Starting with measure how to avoid renal injury post-liver transplantation. Pre-transplant precaution for patient of liver transplantation, limiting use of a non-steroidal and other nephrotoxic drug as aminoglycoside and the contrast, which is done several times during and pre-operative period. Compensating ascites by giving albumin, early treatment of all infection by antibiotic prophylaxis, early management of hemodynamic instability or hepatorenal. Pre-operative renal protection. Many study was done to use several substances as N-acetylcysteine, dopamine, phenol-dopam, hydroxyethyl starch, chloride liberal fluid, mostly for peri-transplant period, maintenance of intravascular volume and mean arterial pressure. As a regular surgical technique, this is meta-analysis done in meta-analysis collected many randomized clinical trial, about 72. No reliable evidence that intervention during surgery can avoid protection. Another prospective study done for comparison of hydroxyethyl starch versus albumin, however, no difference in both. Another one comparing N-acetylcysteine followed by, in comparison to saline, no significant difference in acute kidney injury. Another one, phenol-dopamine, comparison with high dose and small dose of dopamine. However, in a small dose dopamine, 2 microgram per kg, significantly less acute kidney injury and the requirement for diuretic at day 3 in this study. However, in large dose, no significant change. Post-transplantation protection. Control of cardiovascular risk factor. Cardiovascular risk factor for the kidney also, as diabetes, hypertension, dyslipidemia, hyperuricemia. And as diabetes and hypertension is prevalent in about 30 to 70% of liver transplant recipients. Hypermetabolism due to hypermetabolism associated with insulin resistance. Drugs as corticosteroid or tacrolimus may cause diabetes, hypertension, or dyslipidemia. Hyperuricemia, which is a frequent complication after organ transplantation, may improve with allopurinol, which lead to significant decrease in deterioration of kidney function. Hypertension control guideline, all adults with CKD and urine albumin excretion less than 30 milligram per day need to control the blood pressure to less than or equal to 140/90, while patients with CKD and albumin more than or equal to 30 milligram per day need to be treated to blood pressure less than 130/80 millimeter mercury. ACE or ARB should be used in diabetic or non-diabetic with albumin excretion ratio more than 300 milligram per day. ACE or ARB should be used in diabetic patient even with less proteinuria, which ranging from 30 to 300 milligram per day. Salt intake, low salt intake, about 2 grams per day. Low protein intake unless the patient is malnourished. And control of bicarbonate by giving sodium bicarb. Diabetes mellitus control. Post-transplant diabetes has been recognized as a major complication. About 50% of cases occurring within the first 6 months, 75% occurring after 1 year. This is maybe due to insulin resistance, which is related to liver dysfunction and cirrhosis. However, the drug as a steroid and tacrolimus can cause persistent or de novo diabetes following liver transplantation. How to control diabetes? Many drugs are used, but GLP agonist, glucagon-like peptide one receptor agonist, which act by many mechanisms as vasodilator and affect sodium hydrogen exchange 3, which is present in proximal tubule, which is responsible for decreased tubular reabsorption of glucose. And this will lead to the increased tubular proximal pressure and increased TGF transforming growth factor. This all will lead to increased GFR. GLP agonists have many drugs in this family: dulaglutide, exenatide, liraglutide, lexinatide, semaglutide, either injection or oral. It is used in different doses, either for diabetes or weight control. As regards the kidney, it is not recommended mostly in the patient of GFR less than 30 milliliter per minute. Need to be stopped or not well studied if GFR less than 30. No dose adjustment if dulaglutide may be used up to down to GFR more than 15 milliliter per minute. This is many study done for this group showing the effect on the kidney and outcome. Most of them acting on albuminuria, decreasing albuminuria, which is the predictor of renal injury later on. Lexinatide, liraglutide, semaglutide affecting, and dulaglutide, all of them affecting albuminuria. As regards GFR, most of them either no available data or not balance on the GFR, have no effect on GFR, but except dulaglutide, which is showing progressive protection against decrease of GFR. Comparison. This is a study was done for comparison of two of GLP agonists. One of them is dulaglutide and the other is liraglutide for the management of diabetes in solid organ transplantation. It was a retrospective study. It is done in many transplant patients. In our study, in our subject, which is the liver transplantation, it was 16 in comparison to 4 in liraglutide. At the baseline, insulin requirement, weight, and body mass index was higher in liraglutide versus dulaglutide. However, after the end of the treatment with both those drugs, there is a change in GFR and the creatinine in favor of dulaglutide in comparison to liraglutide. However, this change was not significant. And this change was not related to the change in body weight and BMI. So the protection of the kidney by this group is not related to body weight and the BMI, and not related also to hemoglobin A1C. Okay. Conclusion in this study, the conclusions that GLP-1 don't affect tacrolimus level, don't affect the transplant outcome. GLP seem to be effective in controlling diabetes, controlling body weight, but this was unrelated to the control of our protection of the kidney. This is the largest single center experience of dulaglutide for management of diabetes. It is done on 16 liver transplant patients and following them for about 2 years. The difference in the weight and the difference in BMI, there was improving at the end of the 2 years, significant difference. And the difference in estimated GFR, there was a significant difference at the end of the 2 years. Conclusion, both estimated GFR and the creatinine improved during the follow-up period, but the improvement was not statistically significant, but also it is not related to diabetes control and body weight or BMI decrease. Another group for control of diabetes, which is sodium glucose transporter inhibitor 2. It is expressed in the apical side of proximal tubular cells and the co-transport 1 sodium and 1 glucose. 1 sodium responsible for hemodynamic and 1 glucose is responsible for metabolic change. Suppression of sodium reabsorption increase the amount of sodium and the chloride reaching the macula densa, so causing constriction of afferent arteriole. This group is also reported to improve glomerular hyperfiltration of diabetic kidney disease via dilatation of efferent arteriole. On the other hand, suppression of glucose reabsorption improve lipid metabolism, result in reduction of oxidative stress. It enhances free fatty acid oxidative stress and increase production of ketone, body inducing renal and cardioprotective effect in diabetic. This is the figure showing the effect of diabetes in comparison to effect of drug group sodium glucose transporter inhibition. Effect of glucose, blood glucose will increase blood glucose and increase SNG, single nephron GFR filtration. However, the effect of sodium glucose transporter, which will affect on the proximal tubule and decrease reabsorption of sodium and glucose, so will induce natriuresis, and this sodium will take with it chloride, potassium, calcium, phosphorus, and other elements. So preservation of glomerular and tubular and endothelial function. This is many study, and the famous study for using of empagliflozin, canagliflozin, dapagliflozin in general population and in diabetic patient, showing the effect on the kidney, effect on albuminuria. All of them affect on albuminuria and decreasing albuminuria, effect on GFR loss. All of them will affect the GFR. However, initially used this drug act as ACE. It will reduce GFR by about 25 to 30% an initial reduction of GFR, and later on it will restart again to increase GFR. This is a study and the end point for the kidney outcome. Sodium glucose co-transporter 2 inhibition prevent renal fibrosis. The use in liver transplant and in the cyclosporine, which is one of the drugs used in liver transplantation and responsible for fibrosis which occur in liver transplantation. This study was done on the rat, and they divided into two groups: control group receiving placebo, another one receiving cyclosporine by intraperitoneal injection by 15 milligram per day, and another group receiving empagliflozin, and another group receiving cyclosporine plus empagliflozin. After 1 month of follow-up, following body weight, systolic blood pressure, and 24-hour urinary collection, showing that empagliflozin administration causing a reduction in blood pressure in cyclosporine, showing protective effect on cyclosporine nephropathy through decreasing fibrosis and collagen type 1 and 4 deposition or expression. The data suggests that empagliflozin promote nephroprotection also in non-diabetic kidney disease. Post-liver transplantation and modulation of immunosuppressive drugs as CNI, cyclosporine, tacrolimus are the cornerstone and mostly responsible for nephrotoxicity. So the maneuver is to promote the use of tacrolimus over cyclosporine, reducing CNI by adding mycophenolate acid or mTOR, delaying introduction of CNI after induction therapy, or complete weaning from CNI by early conversion to sirolimus. Cyclosporine responsible for the nephrotoxicity, and as Dr. Muhammad Said said, that the upper hand coming for tacrolimus use, not for cyclosporine, but cyclosporine use causing acute nephrotoxicity or chronic. Acute through many type of modality of mechanism of action. One of them is afferent arteriolar vasoconstriction through increasing vasoconstrictor and decreasing vasodilator, decrease prostaglandin, decrease nitric oxide endothelin, and increase thromboxane A2. This is called afferent vasoconstriction. Another mechanism is TMA, which is reported in some cases of renal injury after liver transplantation. It is through increased platelet aggregation and prothrombotic activity, and it is limited type of TMA. It occurs in the kidney, not systemic TMA. And another mechanism is ischemic tubular vacuolation and tubular dysfunction. However, on the long use, this will decrease the GFR in patient and causing salt and water retention and hypertension. However, in chronic CNI nephropathy and nephrotoxicity, this decrease, this afferent vasoconstriction causing glomerular ischemia, glomerular sclerosis, tubular atrophy, and this will end to focal segmental sclerosis, which is presented in the biopsy as a strip fibrosis, which is characteristic of cyclosporine toxicity. Promoting use of tacrolimus, this is two issues, to use high dose or a small dose. However, a small dose, fewer renal side effects at 1 year with no significant risk of rejection, or using the sustained form release of tacrolimus at the graph, limit peak concentration, and reduce toxicity of CNI without excess risk of rejection. This is mainly study done for calcineurin inhibition minimization, starting from 0 day to 1 month, and then from 1 month to 1 year, and after 1 year. Starting from 0 to 1 month, it is a study done of using reduce the tacrolimus delayed to reduce the dose, and starting delayed 6 days versus tacrolimus improve GFR in the reduced and delayed tacrolimus. Another study, standard tacrolimus versus reduced dose tacrolimus plus MMF, and another one reduced the tacrolimus delayed 5 days plus MF with induction induction significantly less drop in GFR in reduced and delayed. This is many study comparing the reduced TAC dose and the delayed TAC dose, showing benefit in GFR and also no significant difference in the rejection rate between two arms. And this is another induction with basiliximab and belatacept high dose plus MMF, another versus belatacept high dose plus MMF versus belatacept low dose MMF, significant better GFR in belatacept group. However, a side effect of belatacept induction therapy as regard adverse reaction was higher in belatacept. Randomized trial for late onset, from 1 month to 1 year duration, week 4 to 12 post-liver transplantation using CNI plus MMF versus CNI conversion to sirolimus plus MMF, significant increase in GFR or significant no drop in the GFR in sirolimus arm versus cyclosporin arm. And another study which is done on about 700 patients, tacrolimus elimination plus everolimus, reduce the tacrolimus plus everolimus or standard tacrolimus. This is showing superior GFR protection for reduce the tacrolimus versus everolimus in comparison to TAC elimination. So it is recommended to continue with TAC, not to eliminate it totally. Another study which is done on induction with basiliximab from the start and the CNI conversion to everolimus or CNI continuation. A significant improvement in GFR with everolimus conversion. This is a randomized trial after the first year of transplantation. Most of this trial going to conversion of CNI to sirolimus, but with good GFR, not to wait till decreasing GFR, because the role of sirolimus later on will be not protective to the kidney. So CNI to sirolimus or CNI from the start, no improvement in GFR with sirolimus. As another one which is done, everolimus plus low dose CNI versus standard dose CNI, no difference in GFR or adverse reaction. However, a study done for MMF low dose CNI versus standard CNI for chronic renal failure treatment patient, significant improvement in estimated GFR in MMF and the low dose. However, in patient with chronic renal failure, the role of CNI may be decreased due to effect pharmacokinetic of CNI in end-stage renal disease. Another one which is done MMF low dose CNI versus standard CNI, but in creatinine, not in the stage, but creatinine more than 1.2 milligram per deciliter, significant improvement in estimated GFR in MMF and low dose CNI at 1 year. We know significant difference in both groups as regard adverse reaction. And thank you.